Greetings from Yenepoya Dental College. I'm Dr. Sruthy Prathap, Additional Professor from Department of Periodontology, Yenepoya Dental College. Today I'll be talking on iatrogenic factors and the periodontium. My specific learning objectives include to know the various iatrogenic factors, the effect of faulty restorations, biological width and its importance, to know about the occlusal discrepancies, the impact of design of removable partial dentures, about the restorative dental procedures and its effects, periodontal problems associated with orthodontic procedures, to know the effect of extraction procedures and the effect of instrumentation roughness. We all know that the goal of periodontal therapy is to provide an environment conducive of oral health. In our day-to-day clinical practice, we perform a lot of dental procedures which, if not appropriately done, can cause more harm to the gingival and periodontal tissues. So, iatrogenic factors are basically inadequate dental procedures which can lead to deterioration of the periodontal tissues. The main etiology of the gingival and periodontal diseases are the dental plaque. So, there are certain dental procedures which can lead to formation of plaque retentive areas in the mouth. For example, this amalgam restoration, if we check the margins, it's not well adapted to the tooth. So, this can act as a plaque retentive area and can lead to accumulation of dental plaque and even micro leakage. And here we have an overhanging restorative margin, which in turn can again accumulate more plaque, leading to gingival and periodontal diseases. And in this picture, we have a removable partial denture, which is attached to the underlying, the adjacent abutment teeth for its retention. So, this clasp, which is very close to the gingival margin, can lead to gingival inflammation and can act as a plaque retentive area. And in this picture, we have a bridge where the margins has a gap or space between the gingival margin, and hence this also can act as a plaque retentive area. And here we have an over-contoured crown, which again can lead to plaque retention. And in this case, where the patient is undergoing an orthodontic therapy, the orthodontic appliance itself can lead to gingival tissue irritation, which is a main plaque retentive area. And the patient also finds it difficult to maintain when he is wearing an appliance. So, what are overhanging restorative margins? It is defined as an extension of restorative material beyond the confines of a cavity preparation. So, in this radiograph, we can identify the overhanging margin here. So, this restoration is extending beyond the confines of the cavity preparation, and we have rough margin here, which can lead to the accumulation of debris and soft deposits, which in turn can lead to initiation of the gingival and periodontal disease. And here we can appreciate the crestal bone loss, which in turn is caused due to the accumulation of the local factors here. And these overhanging restorations can be identified using certain diagnostic instruments like periodontal probe or explorer. We can feel the roughness using the tactile sensation. And coming to the concept of biological width, this concept was first put forward by Ingber et al. The definition is the physiological dimension of junctional epithelium and connective tissue attachment above the crest of the alveolar bone. And basically, it is the area between the depth of the gingival sulcus and the alveolar crest. So, in this picture, we can clearly make out what is biological width. Here we have the gingival sulcus, the sulcular epithelium, and here we have the junctional epithelium, and this is the gingival connective tissue. So, this distance, that is from the base of the sulcus to the crest of the alveolar bone, will give us the width or the biological width. So, that is around 2.04 on an average. That includes junctional epithelial dimension of around 0.97 millimeter and the dimension of the gingival connective tissue of around 1.07 millimeter. So, both added together will give around 2.04 millimeter. So, what happens when there is a violation of biological width? So, when the crown margins are placed in such a way that it encroaches the biological width, there can be some soft tissue reactions what we can expect. Here we can see that the gingiva is erythematous, it has a glazy appearance with loss of stippling, and it has an edematous appearance, and there are certain other inflammatory changes what you can notice, like there is bleeding on the near the gingival margins. So, the initial response to encroachment of biological width include inflammation in the gingival soft tissues. Later on, if in turn it is not corrected, it can progress to periodontal tissue or attachment loss and bone destruction. There are two different responses which can be observed from the involved tissue. So one is the bone loss of an unpredictable nature, and the second one is a generalized gingival recession. So how do we correct the biological width violation? The first method is to orthodontically extrude the teeth. So when we orthodontically extrude the teeth, we shift the margins of the restoration away from the alveolar crest, increasing the distance from the crest to the margin of the restoration. And the second method is by reducing the height of the alveolar bone. So when we reduce the height of the alveolar bone surgically, again the distance between the restorative margin or the crown margin and the alveolar crest increases. And next is a subgingival restorative margin. The location of the gingival margin of a restoration is directly related to the health status of the adjacent periodontal tissues. There are basically three different types of restorative margins. Supragingival restorative margin, which is considered to be periodontal friendly. Equigingival restorative margin, where the restorative margin is at par with the gingival margin. And there is one more, subgingival restorative margin, which is associated with large amounts of plaque, more severe gingivitis and deeper pockets. The subgingival zone or the transition zone is composed of the margin of the restoration, the luting material and the prepared as well as the unprepared tooth surface. And what are the sources of marginal roughness? These include grooves and scratches in the surface of acrylic resin, porcelain or gold restoration, separation of restoration margin and luting material from the cervical finish line, thereby exposing the rough surface of the prepared tooth, dissolution and disintegration of the luting material between the preparation and the restoration, leaving a space, inadequate marginal fit of the restoration. So these are the causes for marginal roughness. And how can we correct it? Minor corrections can be done using fine diamond burrs and polishing stones. But if the roughness is too much, we will have to replace the defective crown by a new crown. Next problem which we commonly come across is the over-contoured crowns. So over-contoured crowns also can act as plaque retentive area, and this will simulate the overhanging restorations. So there are basically three types of scenario what we can notice. In the first one, we have an over-contoured crown, and in this it impinges on the sealing effect of the dentogingival junction. And in the second scenario, that is scenario B, we have an under-contoured crown. So here it inhibits the close adaptation of the gingival tissues to the tooth, which will allow the accumulation of soft deposits in the gingival sulcular region, leading to gingival and periodontal issues. And here we have a normal or ideal crown where it is flush with the gingival tissues, and it allows the self-cleansing activity in the oral cavity. Next comes the inadequate interproximal embrasure. It is often associated with papillary inflammation. Generally, when there is no proper contact between the teeth, that is when the papilla does not fill the embrasure space, there can be accumulation of debris, plaque in the dental region, which can lead to inflammatory response, and it can also lead to further papilla loss. So in this picture we can see the contact is proper and the interdental papilla fills the space, and hence we will not have much of deposition or soft deposits in the interdental region, and it can be easily removed with the help of a dental floss. Next problem what we commonly come across is occlusal discrepancies. Poorly constructed restoration will cause occlusal disharmonies, which leads to primary trauma from occlusion. These include the insertion of high fillings, insertion of prosthesis, replacement that creates excessive forces on the abutment and the antagonistic teeth. So the manifestations of occlusal disharmonies include gingival enlargement, gingival recession, mobility of the teeth, food impaction, pain in and around the teeth with improper restoration. And these occlusal discrepancies can to some extent be corrected using articulating papers. Another common issue is food impaction. Food impaction can be defined as forceful wedging of food into the periodontium. There are various factors which cause food impaction, and Hirschfeld has classified these factors. They are uneven occlusal wear, tooth supraeruption, improper contacts, and improper proximal restorations. So what happens when there is a food impaction? Food impaction can lead to accumulation of food debris in the interdental region, which can initiate gingival inflammation, further lead to pocket formation, and which is followed by bone loss and tooth mobility. Next comes the design of removable partial dentures. So removable partial dentures are given in partially edentulous patients, either as provisional prosthesis or as permanent prosthesis in those patients where there is no option for a FPD, that is when there is no abutment teeth. So when removable partial denture is given, a clasp is used to retain the prosthesis, and this usually engages the abutment teeth, and this can again act as a plaque retentive area and lead to gingival and periodontal tissue destruction. Next comes the relationship of pontic adaptation to the soft tissue health. So pontic also replaces an edentulous area, and it is a permanent treatment procedure, and the main concern here is the degree of pressure, the area of ridge contact, and embrasure space between the abutment teeth and the pontic. Embrasures closed by broad solder joints and over-contoured pontics can lead to initiation of tissue reaction like gingivitis, bleeding on probing. Then it can have hyperplastic gingival reactions. And in the anterior region, aesthetic and phonetic demands require minimal interdental embrasure space. Hence, we make sure that enough space is given in the lingual area so that the patient can maintain it using an interdental aid. So these are the different pontic designs. Hygienic pontic is usually designed in the posterior region, and it does not help in anterior aesthetics. And here we have the conical pontic and saddle ridge lap, modified ridge lap, modified ovate pontic, etc. can be given anteriorly. And other types of pontics include the ovate pontic, step pontic, and the flat pontic. Next comes the restorative dentistry procedures. So when we place restoration and when we do cavity preparation, we use rubber dam clamps, matrix bands, and burrs, which in turn can cause injury to the gingival soft tissues. It can cause laceration to the soft tissues. Although it heals fast, it's a temporary discomfort for the patient. And the rubber dam should be seated firmly on the hard tissues of the teeth and not on the soft tissues. And the clamp should not be forced subgingivally, which may cause tearing of the junctional epithelial structures and the connective tissue of the gingiva. And it should not be placed for very long time, causing ischemia, because this can lead to sloughing of the tissues. During crown preparations, precautions must be taken to prevent excessive gingival abrasion with stones or burrs, especially when there are zones of attached gingiva which is insufficient and where the surrounding gingival tissue is thin and delicate. Next common problem is during the orthodontic treatment. The orthodontic therapy may affect the periodontium by mechanical and chemical irritation. So generally patients with malocclusions like crowding, class 1, class 2 malocclusions, we may give an orthodontic appliance. So these appliances can act as plaque retentive areas, and the patient will find it difficult to maintain the area. And in addition to that, the orthodontic forces which are applied also can directly lead to periodontal destruction, leading to bone loss. So both the magnitude and the type of forces can have an impact on the gingival and periodontal tissue and the alveolar bone. So when the tipping forces are considered to be more harmful during the orthodontic treatment than the bodily movement. Next is extraction procedures. Generally when we extract a teeth, sometimes there may be crush injuries in the alveolar bone, which is almost irreversible because bone takes a very long time for regenerate. And when we use elevators to elevate the tooth which is supposed to be extracted, sometimes inadvertently we can luxate the adjacent teeth or cause pocket formation in the adjacent teeth. So these should be avoided. Next common problem is the instrumentation roughness. When we do scaling and root planing, we use metallic instruments on the tooth surface. That can lead to roughness on the tooth surface by increasing the surface area, promotion of microbial adherence and colonization, plaque maturation, and compromised plaque removal. And hence it is mandatory that after every procedure we do a polishing procedures, especially after scaling and root planing. Next problem is the radiation therapy. In patients, the typical total dose of radiation for head and neck tumor is in the range of 5000 to 8000 centigrades. So generally it is given in patients with head and neck tumors. So this can affect both the normal tissues as well as the tumorous cells, and hence the total dose of radiation can be given in partial incremental doses, because this will prevent the destruction of the normal cells. So generally what happens is that when high radiation dose is given in patients after extraction, it can lead to osteoradionecrosis, which will prevent the healing of the extraction sockets. So I would like to conclude by telling that the faults in the part of dental treatment rendered are common cause of gingival inflammation and often periodontal destruction. The adaptation of margins, the contours of restorations, the proximal relationships, the surface smoothness have a critical biological impact on the gingiva and the supporting periodontal tissues. So it is imperative for the clinicians to perform these dental procedures very judiciously so that it does not harm the adjoining tissues. Thank you.